Okay, thank you, Dr. Bayur.
Now, Dr. Swaraj Bhattacharya is not there, so Jayashree will be speaking on flow issues after posterior capsular rupture. She is the director of Sight Plus Hospital in Jorhat, Assam, and another prolific anti-segment surgeon.
Thank you so much, Dr. Arundhati. So now I'll be continuing with what Dr. Mayur has ended, a PCR. So this is a complication that we all fear, we all dread, because when you're in a busy OT, you know that this is going to eat a lot of your time. So why do we need to understand the flow issues in PCR? Posterior capsular rupture is something that is associated with your vitreous loss that is responsible for 40% increased risk in the retinal detachment. And most of the times it's not because of the PCR, but how you deal with the PCR that causes more of a problem. So if we talk about the physics of PCR, we have two separate chambers, right? We have the anterior chamber and the posterior chamber, and in between we have a membrane. Now, following the fluidics, the flow of the physics of fluids, always there will be the flow from the high pressure zone to a low pressure zone. Now what we are doing a phacoemulsification in an anterior chamber. We have a negative suction pressure, so your vitreous will come from a posterior chamber directly into the anterior chamber, and following the rule that it follows the least resistance. So where will be the area of least resistance? It's your wound, so it will ultimately come out through the wound. So this is what we have to keep in mind. Now, in the causes of PCR, no doubt there may be some inherent causes of PCR, like you are dealing with a PPC with a pre-existing dehiscence. It may be because of your faulty technique. You're learning, and even if you're not learning, sometimes you may go wrong in some steps, and that might be responsible for PCR. But what is more responsible for causing the complications of PCR is the phaco-dynamics and the psychodynamics that is associated with PCR. You know that you have a long list of patients, you try to manage it, jaldi karna hai, but that's not the way. You have people watching you in the OT, they know that you are a brilliant surgeon. You have to let your ego come down, you have to manage the case. So now every single step is important, starting from your incision. As we have already discussed, even the tiniest of the side port leak may lead to a shallow anterior chamber that may be responsible for your rupture. And even the last step, like the IOL insertion, there was recently a video that was circulated in most of the groups. You have a foldable IOL being implanted and the IOL is not to be seen. It was an intact PC, it just shoots into the vitreous cavity. So you may have instances like that. And you have to be very careful with the second instrument. Most of the times we are concentrating on our phaco handpiece. We are concentrating on our right hand instrument for the right-handed person, but we have another instrument that we are dealing with our left hand. So we have to be careful about that. So these are two videos where the last piece, phacoemulsification, ended in a PCR, and secondly, even in case of when you're doing a simple IA, you may end up in a PCR. So a stable anterior chamber is a must, and that has been wonderfully dealt with by my first speaker. So we know how to maintain a stable anterior chamber now. But there are three intraoperative situations that we might encounter. First is we just see the wrinkling of the capsule. Yes, you know that there is a PCR, but then you have an intact anterior hyaloid phase. The second case is when you have the vitreous prolapse. That means the vitreous coming from the posterior chamber to the anterior chamber. And the third is the situation is when you're having a vitreous loss. That is, it crosses even the anterior chamber, it comes out of the anterior chamber. So these three stages might be complicated by the fact that you still have the retained nuclear material or the cortical material to deal with, right? So now, what will be our response? You might not realize that there is a PCR, you keep on continuing your phacoemulsification. You realize that there is a PCR, you panic and just come out. And oh, there is a PCR. Or you take a deep breath, you think, and you try to think what were the steps that were taught in the first talk that we had. So you plan out your agenda, and using your appropriate techniques and settings on your phaco machine, you can definitely give good results to your patients. So we have a new set of goals now. We have to prevent the vitreous loss. We have to keep our rexis intact so that we can implant the IOL and complete the case now. So this is, if I want to ask you, what is the single take-home message from today's talk, it is that you need to avoid the vitreoretinal traction. No active phacoemulsification when you diagnose a PCR, because the phaco probe is a very good aspirator. It's a very strong aspirator, but it's not a cutter. So it can aspirate and it will separate your neurosensory retina from the RPE. And this RPE pump pressure, is just 0.27 millimeter mercury. So it's easily overcome. So you have to avoid phacoemulsification. First, early detection is very important. For this, just the 3 hours by Dr. Howard Fine, you see that suddenly there is increased space. You have enough space for performing phacoemulsification. You see that the pieces that were coming to the center with your second instrument is not coming smoothly, and you feel some resistance. Phaco was being performed well, but you feel some resistance, and sometimes you may hear the occlusion sound even when there is no nuclear material occluding your phaco tip. So at the very suspicion of PCR, you need to stay calm and you need to signal your team without the patient knowing that yes, you have had a PCR. So they have to be ready with whatever essentials that is required, including the lowering of your parameters. Don't take out any instrument, don't move any instrument, just go to foot position 1 and stop your phacoemulsification, continue the irrigation. And your assistant must know what are the things that you'll require now. It's not that once you have the PCR, then you go about searching for your vitrectomy consumables. It's not like that. It's something that you have to keep that vitrectomy kit. It's a must for every phaco surgeon. You need the vitrectomy consumables. You need a separate set of SICS, ECC instruments, since you might need to convert the case. You require a dispersive viscoelastic. You need triamcinolone to stain your vitreous. You need pilocarpine and an IOL of appropriate power that might be required to replace it. So these are strict no. That is, once any nuclear remnant has crossed your PC and reached the posterior surface, don't hesitate to give the case to your vitreoretinal colleague. Because we have a tendency that no, I don't want to send him to a retina colleague, so we go about fishing. We go with a phaco probe into the posterior capsule. That's not allowed. You cannot use any instrument inside, because any amount of instruments that you are using and the traction which you are using is sufficient to cause your retinal detachment. And don't think that the fluid will lift up your phaco, your nuclear pieces. No, it will not do. It will work in AC. It will not work in the vitreous. So no amount of irrigation like in the third picture is going to work in this case. So go slow and stepwise. First, maintain the pressure gradient, which is the most important point. Then deal with your nuclear fragments, do a good vitrectomy, and complete the case. Now, do not let the interior chamber collapse at any moment. So, as I have already mentioned, don't take out any instrument. Just take out the second-hand instrument that you are holding. See, there is a PCR in the last moment. So, inject the dispersive viscoelastics. This will do two things. One, it will float your nuclear pieces upward. And secondly, it will give a protection. It will form a seal over your PCR. So remember another thing, that viscoelastics are cheaper than your vitreous. Don't hesitate if you need to use even 2 bottles of dispersive viscoelastic. This is a very important point because it will prevent your cataract pieces from falling back into the vitreous, and it will prevent a long-term complication associated that the patient might have to go through. So the same thing here, just take it out and just inject your dispersive viscoelastic, and only once the chamber is fully formed you can take out your phaco probe now. So this is what I have already said. One is we seal the rupture area, and secondly the pieces they float up, and then you can go for the management of the nuclear pieces. If you are in a doubt that whether the vitreous has come out or not, whether there is actually vitreous loss or not, this is another strict no, because again where you are causing the traction, where the adhesions are more, that means you are causing a traction at the vitreous base. So this is again not allowed. You have any doubt, go for triamcinolone. It is easily available, it is cheap, and it will help you to detect the vitreous very clearly. So triamcinolone, even at the starting, when you are starting the vitrectomy, and also at the end after completing your case, just to find out whether the vitreous is there or not, use a separate incision for your vitrectomy. Now, as regards to whether we should go for coaxial or bimanual, yes, my preference is a bimanual, because here you have the irrigation port above and you have the vitrectomy probe which is working down there. But in coaxial, you have it at the same point, so it's hydrating your vitreous as well. So this is paracentesis anterior vitrectomy, but we can also go for the pars plana vitrectomy because this is more physiological. This is the vitreous stays where it is actually supposed to stay. So most of the machines, they have two modes of anterior vitrectomy. We have the cut IA to remove the vitreous and the IA cut to remove the residual lens matter. The difference between this is that in cut IA, you have irrigation. In foot pedal 2, you have the cutting, the vitrectomy, and in position 3, you have the aspiration. Only after cutting the vitreous, you will have to aspirate it and not the vice versa. I'll just take 1 minute more. So regarding the parameters in cut IA, we have to take the highest cutting rate that is allowed in the machine. So in conventional machines, it is 1500 to 2500 cuts per minute. But in cases with the latest machines with active fluidics, you can go up to 5000 cuts per minute. So the more is the cutting rate, the easier is the vitreous removal. So the same thing, the vitrectomy is in progress. And I would like to mention that this movement with the vitrectomy tip that you see, it's only at foot pedal 2 when you're doing the cutting. So IOL implantation will depend upon your residual capsular margin that is there and the residual nuclear material that is there. You might need to enlarge your incisions. And for the IOL implantation, if it's a small PCR and you know that you can still go away with the foldable IOLs that you had planned. Otherwise, a 3-piece IOL as seen in the second case with the sulcus fixation is it's what is suggested in most of the cases, or you can go for a rigid PMMA IOL. So another thing is that at the end of the case, please don't forget to give a suture. Retropupillary iris claw lens is another important alternative that can be observed as a very good alternative to SFIOL. Here all you need is to extend your incision, and I am just showing this video for the greater interest of all the people so that if you don't have a facility for a SFIOL, you can easily go for this types of IOL where you just need to nick the iris tissue into the haptic gap that is present, and that's fine. And then at the end of the surgery, you have a perfect retropupillary iris claw lens like a PC-IOL itself. So post-operative course is a bit longer, but using these appropriate technologies and settings in our phaco platform, we can optimize the situation and minimize the vitreous loss. Thank you so much for your patient listening.